Hi guys, welcome back to Sheri Approved, and the day is finally here with Ask the Doc. Okay, so this is going to be the first in what we hope to be a series, and I am here with Dr. Sabrina Ramkisson. So excited. This has been my gynecologist for the last 2 years or so, and I mean, you guys would have heard me talk about her so many times of how impressed I am with how she has dealt with me, how she's given information, how she shares, and I wanted to be able to share that. And Dr. Sabrina is very open, and she wholeheartedly agreed to do this to give you some information on some of what we call the hot questions that we have, the taboo topics or things that people are not talking about or things that there is misinformation about out there, and there's a lot of it. So, ladies, welcome, and this is Dr. Sabrina Ramkisson.
Hi, so it's nice to meet you all. When Sheri first approached me with this, I am somebody who is all about getting education, awareness, letting women need to understand about their body, and I think that's where we're falling a little short. So when she told me about this, I was very excited to get, at least this avenue where we can answer some of your questions, because sometimes there are a lot of myths out there.
Oh, yeah.
I think people, they hear something or they read something, and there's so much information online a lot of times that it makes it difficult for you to focus in and think about what really is important, what really matters. So
what's
that's
truth?
what we're here to do. And what's truth? Yes,
Right.
that is correct.
Good. So, to start off today, we want to talk about, I think, what would have been the most popular topic that I got questions on when I asked you, what do you want me to ask the doctor, right? And so many of you asked about this thing called PCOS, Polycystic Ovarian Syndrome. So let's deal with it. Let's get the basics. Let's get the points that we need to know, and let's see what we're going to find out. So, Doc, tell me, what is PCOS?
Okay, so PCOS, Polycystic Ovarian Syndrome, is something that comes from your ovary. So that's where ovarian comes in, right? So it is something that happens within the ovaries. We have two ovaries, so there's one on the left, one on the right, and these are what actually have our eggs in them. So once we're born, we actually babies, and we have millions and millions and millions of tiny little follicles, which I like to compare it to grapes.
Right.
So I say that you have these two ovarian sacs, and they're filled with a lot of grapes in them. And within the grapes, you have seeds. So grapes have seeds, right? So that's actually our follicles, which are the grapes, and the seeds are our eggs, or our future eggs, which we hope to get pregnant.
So you have many grapes,
You have many
and each of those grapes have seeds.
and they have seeds, right? So along here, you get your periods, things are maturing, your ovaries are maturing, so these follicles actually can mature. And at any cycle, so with any menstrual cycle, within the first couple of days when you actually are bleeding or having a period, there are a few of them that the grapes are going to get a little bigger in size.
Okay.
Right? So a few of them get bigger in size, but they're only supposed to be about 10 to 12 of them that are present in the ovary around that time. And eventually one of the grapes will become a lot bigger, and that one is the one that's going to hopefully ovulate and release our egg. So that's just explaining to you the anatomy of the ovary, so that we can then talk about what is PCOS and what's happening there. So PCOS is a sort of a malfunction that happens in the ovary with these follicles. So we're supposed to have about at least 10 or 12 of them. And with PCOS, and I'll tell you how it happens afterwards, so what causes the PCOS, these follicles multiply. So instead of having just 10 or 12 of them, we actually have 15, we have 20, we have 25. So when you look at it, and the most common thing that we use to diagnose PCOS is a pelvic ultrasound. So that's an internal ultrasound. You actually see it. And I do a lot of my posts on my Instagram page as well, where I show you the ovaries and I show you what these extra follicles look like on the ovary.
Right.
So that is what happens with the ovaries. And that can either happen two ways. So it's actually, some people are not aware of this. It's actually a family history line. So it's a hereditary thing. Yes.
Okay.
So in our slim girls, because we sort of relate polycystic ovarian syndrome to girls who are a little more overweight.
Correct.
Right. So you would popularly hear, if your body mass or your BMI, which we could talk about what is that and all of that a little later on. If your BMI is higher than it should be, higher than ideal, which is ideal being 20 to 24, then with the weight itself sends signals to the ovaries, and then there's a malfunctioning where the follicles are overproducing themselves, right? Now it also not only weight related but hereditary. So along the family chain, now sometimes it skips. So you might have, your mom might be okay, you ask your aunt and you say, do you have PCOS? And she says, no, I'm fine also. It has been shown that it skips. Right? So somewhere along your chain there may have been somebody that was suffering, and back in the day grandma never scanned herself.
Exactly.
So there's a lot of kind of the unknown that we
so
don't
they may
know
have been
if
in
they
history.
may have. Yeah.
No, right.
You might not be picking it up.
So you mentioned, for example, the slim girls. So a lot of times we may be relating it to those who may be overweight,
Yes.
but those who may be the slim girls who are diagnosed, usually it could probably be because it's hereditary.
Familial, yeah.
Wow, okay. Look,
Yeah.
I learned something because I didn't know that. Okay, good. So we know that could be one of the causes.
Yes.
And of course, the weight also being an issue. Are there any other causes or things that may trigger PCOS?
Most commonly, those would be the most common factors that cause it. There are some that fall into a bracket where there's no known cause, and in medicine we always have a small group where there's no known cause. But for the majority, it falls into either of those two classifications.
Okay.
Yeah.
So you mentioned, for example, the internal pelvic ultrasound.
Yeah.
So that's how they are able to see if you have these extra follicles.
Yes.
So is it that the follicles will remain there all month because you mentioned that particular time of the cycle?
Right.
So is it that you need to come
Very
in?
important question.
Is it that you need to come in for the ultrasound at a particular time of the month in order to see if that's happening, or do they disappear, or what happens?
So it is always advisable. You have the first half of your period. So most women have 28 days, right, which is called a cycle length. And that is divided into two, so that by day 14 you might commonly read or hear that you ovulate around that time. So you have the 14 days before that time, and then you have the 14 days after that time, right? Now, most of the follicles will develop themselves in the first half, right? Whereas in the second half, you're not going to see any of these follicles. So ideally, if you really need to scan and be sure, the second half would be the better half, because if you have PCOS, they would persist.
Right.
So it means that the time before the first 14 days, you can just kind of actually have a lot of follicles developing, but it may not be polycystic ovaries.
Okay.
Whereas if you have these follicles, then they sort of sustain, so they stay in your ovary, and then you would see them in the latter part, so you know for sure it's okay, I have polycystic ovaries.
That's so interesting.
Yes.
So it makes sense that if you want to check or you suspect, that you should probably schedule your appointment, of course, in the second half of your cycle.
After your ovulation time. But having said that, polycystic ovaries has it has a definite look.
Okay.
So even if you come in your follicular or your time, your first 14 days, we still can look at the patterns of the follicles.
Okay.
Because they tend to make themselves around the periphery of the ovary. So you see what we classically call a string of pearls. Yeah.
Right.
So you can see that even in the first half, even in the second half.
Okay. Now, so we're talking about an ultrasound and you're seeing these follicles.
Yes.
Are there any other symptoms or other ways that they
signs that we can see? So it always amuses us when we can diagnose polycystic with just looking at somebody, because some patients say, but doc, how can you tell I have polycystic, by just looking at me? But there are certain things that we look at. So there are two things I need to say at this point. Polycystic ovaries, you can have two things. You can either have polycystic ovaries alone, where we pick it up on ultrasound, but you don't have this syndrome because you're not manifesting the external features, which we'll talk about. Or you can have polycystic ovarian syndrome, where you both have the ovarian changes as well as the external changes.
So let's make a clear distinction there.
Yes.
We have both. Some people could have polycystic ovaries and not the syndrome.
Correct.
But then there's also the ovarian syndrome, where you would have the polycystic ovaries in addition to these
other external factors and all of that. Yeah. And it's the polycystic ovarian syndrome girls that have to be a little more concerned later in life, because you have a lot of things like blood pressure related problems, diabetes, and its onset. There is a higher chance of womb cancer. This is obviously a rare group, so I don't want to scare anybody.
Right.
But the lining in the womb can get a bit thickened if you're not getting regular periods, and with that you can build up, and later on in life you'll become a risk factor.
Wow. Okay.
Yes.
So I didn't even know that. I know, for example, we hear a lot about, for example, fertility issues are possible and that kind of thing. But this is really important information.
Yes.
So basically the doctor will go through, your doctor should go through with you those signs, those things that they're looking for. And what are some of those things that they're looking for?
So if you've had your gynecology visit, you might ask, these are common questions that we ask. We would first start with I tend to go stepwise from head to toe.
Okay.
So I would first ask you, is your hair on your head dropping? Because
right.
some women have a lot of that hair dropping.
Right.
Then we would go on to the face. So we would then ask about acne flare-ups, whether you've noticed any change or has there been, because some women, they're fine for a few years, but when the polycystic ovarian syndrome is kicking in, they notice a drastic change in the acne.
Mm-hmm.
Right?
Okay.
So it's noticeable, and that's what brings them to the doctor.
Right.
Because they might have one or two things over
and
the
is
years.
it usually all over the face, or usually, I know for example, around that time of the month, I will get hormonal breakouts, and usually in the lower parts.
So it tends to work itself around
in this,
hair.
okay.
I don't know, you also do makeup, so I don't know if you know what these areas are called.
Mm-hmm.
Yeah. So we get them in the more of the oily
the T-zone and that kind of thing.
T-zone and that kind of
thing. Okay.
Yes.
So they will actually notice an increase in the breakup.
Increase in that.
Okay.
Then there's a lot of facial hair. So there are a lot of girls that every 2 weeks they have to be waxing, or some use facial hair removal, and you would hear them say, every time I wax, or I think I have to do it 2 weeks later. So there's a rapid or a lot of facial hair growth.
Okay.
As well as you can notice more body hair.
Okay.
The acne, having said that we see it on the face, some women get it on their back.
Right.
Some women get it on the buttock area.
Yeah.
So
okay.
that's.
So they hear the acne, and you were saying from head to toe, what are the symptoms or signs you'd see with the rest of the body?
So you might see the acne in other places.
Mm-hmm.
And then of course we look at the central area.
Okay.
So we're particularly looking at central obesity.
Okay.
Because that I need to make another distinction. You have girls that walk around different body types.
Right.
So there's some girls that are slim, but hereditary.
They carry weight in the
I'm one of those. That hereditary, you could develop a lot of central weight.
Okay.
So the girls that have a central weight, the fat cells in this central area has estrogen, which is female hormone.
Right. Mm-hmm.
I would have told you this, I think. And it converts it right in these peripheral fat cells to testosterone.
Okay.
So that testosterone, in polycystic ovarian syndrome, you have more testosterone. There's an imbalance. Testosterone is a male hormone.
Right.
And estrogen and progesterone are
female hormones. Right.
So there becomes an imbalance as well. And when we find the central area, we know that this is also the culprit.
Okay.
That can be increasing testosterone.
Right.
And then the whole polycystic ovarian syndrome and all of those things.
And that's why they kind of call it a cycle,
yes.
right?
Yeah.
So tell me something, and what about the menstrual period? Can somebody have a regular menstrual period and still have PCOS?
You did your research, huh? You asking all these targeted questions. It's really good. We did not prepare before. So Sheri is correct. The periods then, a lot of you would notice that your periods start changing.
Okay.
Now you may not necessarily jump into irregularity.
Okay.
Some women actually notice there's a gradual change.
Mm-hmm.
So you might start seeing your length between one period to another lengthening.
Okay.
But having said that, periods and the length between can be anywhere in a range from 21 days to 35 days. That's still considered normal. Where most people have a 28-day, you can still have a range.
Right. Mm-hmm.
Having said that, when you start counting your first day of one period to the first day of another, you might start going from 20 to 32, 33, 34. So month by month, your length in between one period to another is lengthening.
Right.
And then when you start going over 35 days, we know that the testosterone and all of the polycystic ovarian syndrome, it's all related to lengthening your period cycles, making them more and more irregular as well.
Right. So for those of you who saw my live on skincare and hormones, I was telling you guys, make sure you have the apps on your phone. You need to be tracking your menstrual cycle. When you go to your doctor, you need to say the day of my last period.
This question we asked
was January 2nd, and the one before that, and the one before that, because they are going to use that information in order to properly diagnose you. And if you're not checking,
then you would have no idea what's regular, what's normal, when you should be concerned. And for a lot of my patients, it makes me laugh all the time. Their husbands know. So bring your husband, bring your boyfriend, because I get a lot of information from them that you're doing.
Wow,
but they're very supportive. I think men are very supportive.
Yeah.
Because they keep track, they tell you, your period your period is lengthening. Some men know, they're very aware.
No, but that's so important because I think I've realized, even from talking to people on a regular basis, certain things come up and I'm like, so have you noticed changes with your periods? I'm not sure. How long is your cycle? Cure.
Yeah.
Some of them don't even understand these terms, and this is one of the reasons why we're doing this, because I think it's so important for us to understand this. Okay, so if I have been told by my doctor that I have polycystic ovarian syndrome, what is the next step for me?
Right. So the next step would obviously be, how do we manage it? How do we deal with it? Because of course you've raised an important point, fertility. So there's some girls that are actually, how they present to me is that they would say, well, my periods have been lengthening a little bit, and I also noticed for the last 3-4 years I've been with my partner and we haven't gotten pregnant.
Okay.
And we're not using birth control. Right. So that brings fertility on the table. So I sort of go through everything with them in terms of how we're going to manage everything. But we start simple. So lifestyle changes have been shown time and time again to be of utmost importance with managing. So again, we spoke about the BMI, your body mass index. So I encourage all of you to calculate it. Sheri, I think you should post it up too, so that we can get all of those to post there. It's a simple calculation, but it puts you into perspective. Are you ideal with your weight for height? Do you need to lose some weight? And you would be surprised, a lot of girls that actually focus on losing the weight, the polycystic ovaries get back to regular. Because what you do is, when the weight is more ideal, your female hormones are balanced better, and your ovaries are not confused. Because remember I said in the beginning, polycystic ovaries is where the ovaries they malfunction.
Yep, I actually have that as my own personal experience. Because like maybe about 6 years ago, one day I just said, listen, I can't continue like this. I lost 45 pounds or so.
Wow.
From the time I lost that weight, my period went back to like dead, on schedule. I was so shocked at how much of a difference that made.
So because ideal weight, and that's why I keep posting it and I keep encouraging girls to calculate it, because it puts you into perspective. It tells you how much weight you need to lose, and you'll be surprised. You don't need to take pills. Polycystic ovaries or ovarian syndrome does not have a cure. So I cannot just write a prescription for you and tell you, take this and it's going to go away. You have to commit to a lifestyle change. And as you said, when you committed to it, you were living proof.
Yeah, exactly.
And that's what I want to encourage girls to do. It's the simple things. We don't have to give you tablets. You come to, some people think you come to the doctor's office and they give a prescription. If you don't get a prescription, something wrong.
Because that was going to be one of my questions. Is there a cure?
A cure, right.
And there isn't. So you need to manage it. And with managing, you could actually try to reverse the problem that you're in.
Correct. And you will start to see your periods that are now lengthened. As we talked about, they're going to start to come back into a regular range. And then you know that things are balancing. Having said that, there are some people that may then ask, Metformin or Glucophage, right? So you may have asked me that. It is a tablet that we use, but I'm saddened to see its overuse. I wouldn't say, I don't know if it's in other countries, but I find in Trinidad a lot of girls who are underweight or on normal body mass index weight, they have been put on Glucophage and Metformin. Well, it's the same thing, but it's just different brands. So I'm just saying the two because you just want to make sure there's clarity on that. But what it is, polycystic ovaries, as I said, or ovarian syndrome, you then become a pre-diabetic state. Right? So it is associated with something called insulin resistance, right? So what that means is that your insulin, which is a hormone that's produced in your body to break down your things in your diet, so to break down the fats, the proteins, everything that you take in your carbohydrates, to break it down properly, you need to have that insulin functioning well. In the girls who develop polycystic ovarian syndrome, their insulin is being produced, but the receptors, so receptors are just like things on our cells that are supposed to read.
Like a sensor.
Yeah, like a sensor. So they don't see the insulin, and that's what we call like insulin resistance. So you have insulin, but your body's not using it correctly. So when you take things in your diet, it's not breaking down in the right way, and then that makes you now at risk of your sugar going up, and that's what pre-diabetic stage is. So Glucophage or the Metformin it makes your body insulin sensitive. That's its function. So we particularly use it for girls with a higher BMI because these girls are the more insulin resistant girls. Having said that, not all polycystic ovarian syndrome girls have insulin resistance. So
it's not necessary. It's not necessarily that one equals the other.
So some girls may be afraid, or they may think, well, if I'm pre-diabetic, it may not be you. And the smaller girls who it's a more hereditary problem, they are not really the girls that suffer with the insulin resistance. It's more weight related.
So what I'm gathering so far is that you really need to sit down a one-on-one with your doctor, because every case is going to be different.
Very true.
And based on your case and your symptoms and what's happening, your family history, all that, your doctor will help you develop a plan.
That's correct.
To manage.
That's correct.
So we talked about metformin glucophage, insulin resistance, losing weight, and what about diet?
Yes.
What
So
about
diet is pretty much, now there are nutritionists out there, so sometimes I tell women who's struggling with, especially with weight, because it becomes resistant weight that
correct,
on.
it's difficult to come
and you're
up
in a vicious cycle, and it's
Mhm.
frustrating, and then they give up, and within about a month's time they say, this is not for me, I can't do this, right? So I would encourage these girls to actually get a consultation with a nutritionist,
Okay.
because a nutritionist can point out for you portion control, which is important, exactly the types of foods that you need to be putting in, because we're looking at things like provisions. You're looking at things less carbohydrates, less white things, so less white rice, less white bread,
Right.
less pasta. So there's a whole list of things that you really have to actually just cut out. People
Okay.
say, do I reduce? Should I just eat? Yes, my thing is
Cut it out.
because you
So-
want to,
What about things like now, for example, like gluten-free and all
Yeah.
of that? Are they related? Do they, do incorporating those type of foods or that type of diet help?
Yeah. Well, a gluten-free diet is always advisable, I think.
Really?
And we've been noticing a lot more gluten allergies. So there are women that get breakouts on the arm area, or they get little hives in certain areas. They have a lot of abdominal pain to digest and all of that. So for those girls who we encourage gluten-free, a gluten-free diet I think is a healthier diet naturally.
Yes.
Yeah. So you polycystic girls might also
Benefit from it.
even though a gluten-free diet, having said that, is challenging.
Yeah, it is.
But I think a nutritionist, if you just don't know what to do, how to do it, I can guide you up to a certain point, but I think that sitting with a nutritionist and having a consult is also excellent.
But I can also say, because I at one point in time I had gone completely gluten-free, and you can tell the difference in your body because you will feel different.
Yes.
Besides all the other benefits, you get a lot more energy and that kind of thing. Like, it's the first thing to think, wow, something was really holding you down or feeling you, making you feel sluggish, and now all of a sudden that's gone.
Yes.
So yeah, for sure. Okay, great. So well, I wanted to ask about the thinning hair, because somebody asked about that. Is that one of the signs which you mentioned?
Yes.
So what about dealing with that, hair dropping and that kind of thing, if you have polycystic ovarian syndrome?
Right. So the thing is that everything sort of reverses itself, as we chatted about, once you sort of pull yourself back.
Because that will be related to the hormonal imbalance.
Everything is related to the hormonal imbalance.
Okay.
Yeah. Now there are certain remedies, at-home remedies. I think there's some people, we really have to focus on strengthening the follicle, the roots.
Okay.
Right. So some people, your grandma, what they used to advise, oil and
they put castor oil and
castor oil, garlic.
I heard people rubbing onion juice and all kinds of
Yes. So I'm not here to dispute those things, and honestly I've seen those things work, right? But the thing is that there's nothing that you can take to really stop it, and I don't really advise women to take things like Rogaine and all of these unwanted things, a lot of these products. I would just say, wait, when the change happens and you get more control over yourself, women have told me that they see less dropping.
Okay. What else is important for people to understand about this? Because I know for a lot of people it's a challenge, and they feel frustrated and that kind of thing. So many girls would have told me that they feel tired because they go to a doctor and they feel that they just get a prescription for birth control.
Yes.
Pill. In fact, some people were asking about, is it possible to manage PCOS without having to take birth control? And I think that's something that you probably need to discuss with your doctor, again, depending on your situation, because your doctor will be able to advise best.
So
but what do you have to say about that?
Yeah, so I can touch on it. Now, as I said before, with polycystic ovaries, when the cycles are lengthening, it means that you're having less frequent periods.
Right.
Now, having said that, women do not really need to have a period every month.
Okay.
Right?
Okay.
Sometimes there's some birth controls. I know there's some birth controls where you get 4 periods a year.
Right.
So the important thing there is that, and as you said, it's different. You need to sit with your doctor. They need to find out how infrequent are your periods. Because if you're falling into the bracket where you have less than 4 periods a year, then we would advise that we do something to bring the periods down.
Okay.
Because the fear is, as I said before, if that lining is thickening because you're getting infrequent periods, then you then later on you're at risk for endometrial or womb cancer, because that's where it comes from. It comes from the thickening of your lining. So in those girls, we may want to encourage things like the pill, because with the pill it has estrogen and progesterone, which are the two hormones that are imbalanced in polycystic ovaries.
Right.
So we try to then give some of that externally, and that sort of then can balance the hormones a little bit, have your periods come down so that we're not thickening up that lining. So there would be some girls it would be advisable.
Right, and as you mentioned that though, I mean, I know a lot of them who are on the pill for that purpose.
Yeah.
And then of course they come off the pill and they notice back to square one.
Yes.
So is it for some people that this is just going to be something that you have to do, or I mean, you would critically try to encourage them to do those lifestyle changes? If you want to at some point probably have to come off of medication.
Yes.
You definitely need to make those changes in the way you live.
Yes.
Otherwise, it's just going to continue, right?
It's just going to continue, because unfortunately, it's the easiest thing to go wrong. The ovaries just love to misbehave when you've already had it happen. So it's a constant struggle. And I think that's where we lose a lot of women, because, they think that, I'm doing this and I'm not seeing any changes. Especially with the girls with the higher BMI, I encourage the use of the glucophage or the metformin, because you want your body to see its insulin to break down the things in your diet better. But it's a lifestyle change. You actually have to commit to a change.
I have two more questions. Sure. One is with regards to the metformin and the glucophage, because in a lot of forums I see people talk about the fact that the side effects and how do they manage it. I know many years ago when I had to take this, a doctor would have told me start from a lower dosage until you get to the dosage that they want you to be at. I've seen some people say they've just gone to, I don't know, 3 a day, different things, and having the run into the bathroom, the nausea, that kind of thing.
With nausea. So sometimes some people feel very lethargic, they can't function in work, they have to take a sick day. So my advice to that is that there are a lot of generic brands on the market. This is not to speak the brand, but this is just to focus your attention. There are certain brands. There's one in particular called the GL500 brand that is less side effects.
Okay.
Right? Whereas there's some that are more side effects.
Okay.
So maybe if they message, with particular brands, I can clarify that for you. But again, another thing that's very important, as you said, start with a small dose. So don't jump and take 1, 2, 3 tablets at a time. Start with a half.
Correct.
And I say start with a half, 2 weeks, do the half, even if you have to do a full month of the half because you're feeling a little bit queasy or a little something. Do it slow, right? It's a gradual thing. And every 2 weeks or every month, increase by a half.
Right.
Until you get up, and every woman is different. So some women may only need 1 or 2, some may need 3 or 4. It just depends on your weight, how resistant your insulin is, and all of those things.
Right, and of course your doctor will guide you as to how much it should be.
As to how much, yeah.
Okay, and the last thing I wanted to ask you is, what else do you have to say, about this? What else do you think is important for people to know?
I think a big thing that I need to say is I think it's being overdiagnosed.
Right.
Yeah.
Yes.
So I think that 50% of the population comes and says they are polycystic.
Yes.
That's not a realistic statistic.
True.
Right? The incidence of polycystic ovarian syndrome is about 10%. 10
Wow.
to 15%. So that means out of 10 girls, only 1 or 2 at most should be diagnosed with
Okay,
this.
wait. Because every other girl that I know says, I have PCOS too, and we hug and we cry and we say we have it together, and let's form sisterhoods and lots of support groups. But that's one of the things I remember you telling me. You think that it has been overdiagnosed.
And there's another thing called multifollicle ovaries, right? Which I think some people, or this is just awareness. This is not me saying anything negative against anybody, but I think that is also being confused with polycystic ovaries.
Right, which is what you mentioned earlier.
Yeah. So some women's ovaries they have a few of the follicles and a little extra, but it's actually not the polycystic changes. So the polycystic, we said string of pearls,
right.
Or you kind of look at the pattern of it. Multifollicle means that at any point in time you may have 10 or 11 follicles.
Yeah.
So that is another. I would encourage you to get a pelvic ultrasound done. Now pelvic ultrasound is an internal, and that's only if you're sexually active.
Okay.
Right? Don't let us be the ones to take that
Okay.
virginity away.
No, that's important.
It is
That's
important.
Mhm.
So if you've never been sexually active, you would need to have an abdominal ultrasound where we put the probe on top.
Right.
Now, having said that, you see the ovaries a lot less from doing a scan above, or some patients are being misdiagnosed there as well, because we put in the probe on, you're seeing the ovaries, that's polycystic.
Okay, but you can't really see it as
can't really
right.
differentiate because the probe is all the way up here and the ovaries are all the way down in your pelvis. So that's why the pelvic one sees the ovaries much more detailed. So
Okay.
these are all the things that.
Wow. Well, I mean, I think that was, although just a little bit of information, quite comprehensive based on the kinds of questions that we have with regards to polycystic ovarian syndrome, especially here in Trinidad. And perhaps you may need to get a second opinion. Perhaps you need to go do a pelvic ultrasound. Perhaps you need to confirm. Perhaps you need to, just sit down and rethink the strategies that you're using to manage. Perhaps you need to look at which brand of metformin you're using. So a lot of things to consider. And I highly recommend you come visit Dr. Sabrina. No joke, I'm telling you guys. I highly recommend it because, what she just said with regards to the ultrasound, I had to come to see her to do something. And she said, you know what? We're not seeing the ovaries very clear today.
Yeah.
And she would not make a diagnosis or something like that if she's not seen it clearly. Let's do it again, So that's what I really appreciate, her honesty. She takes her time to go through, all your symptoms and your case and then advice. So, your call, please.
I'll have to get Sheri to manage me with all these calls, Sheri already sends, I think, half of Trinidad.
No, because I think it's necessary.
I appreciate that.
I think it's really necessary. And you all know I'm not going to put my stamp of approval on just anybody. And
so I'm Sheri approved.
Very Sheri approved.
And I was also husband approved back in the day.
yes. The husband came, and after the first visit, he said, I like her. So, no joke. You brought up a really important point, bring your partners with you to that appointment. It's good. Because the discussion that comes out is going to be helpful to both of you. So, this ends just segment 1 of the series that we're doing with Dr. Sabrina. I hope that this was helpful for you. If you have any questions, queries, concerns, please feel free to comment below. We'll try to help you or direct them to Doc, and let's see how we can get you some help. Bye.